Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. Today we're going to discuss arterial blood gases and acid-base balance. So this is the Great Adventure, and we are in the fifth of a series of 30 presentations on the topic of pediatric pulmonary physiology. So I want you to approach this again like a kid in a candy shop, and we're going to talk about arterial blood gases, P-arterial PO2 and P-arterial CO2. We previously talked about how to calculate these. Acid-base balance, which will be the main part of this, and then acute or chronic CO2 retention, and what? No blood gas? You'll see what that's all about. So arterial blood gases, specifically P-arterial O2 and P-arterial CO2. Normal lung function is defined as the maintenance of normal arterial oxygen tension, carbon dioxide tension, and pH without excessive cardiac or pulmonary work. Remember that it requires adequate ventilation, adequate perfusion, and most importantly, that ventilation should be distributed throughout the lungs where perfusion is. And of course, we know that there is no significant impediment to oxygen or CO2 diffusion across the alveolar capillary membrane, at least at sea level. So when we measure blood gases, all right, so it turns out that PO2, PCO2, and pH are measured. And these are a direct effect of lung function. They can be sampled from many different sites. Of note, on a blood gas, arterial oxygen saturation, bicarb, and base excess are calculated. So with a blood gas, PO2 reflects oxygenation, PCO2 reflects ventilation, and pH reflects acid-base status. So let's talk about oxygenation. The PO2 measures oxygenation, and it's determined by the amount of oxygen entering the lungs. PO2 can be increased by increasing ventilation, increasing the fraction of inspired oxygen or supplemental oxygen, and in mechanical ventilation, increasing mean airway pressure. So in terms of how one can increase arterial PO2, basically we could reduce O2 consumption, but that's putting someone into shock. We're not usually going to do that. So you can increase alveolar ventilation, VQ, or PiO2. PO2 measures oxygenation. We can measure an arterial blood gas, arterial PO2, from three sites. Our arterial PO2 is the best measure of lung function because this blood comes directly from the lungs. A capillary PO2 is somewhat unpredictable measure of oxygenation, and it depends on perfusion and ease of blood flow. So when I was an intern and resident in the early 70s, we actually had to draw all of our bloods. So if I was drawing a capillary blood gas on, for example, a baby, I knew that if I poked the heel of the finger and red blood was free flowing, that this was probably going to be a pretty good estimate of arterial blood gas. On the other hand, if I had to squeeze a heel that had been poked every day or several times a day for the past several weeks, and this black blood barely comes out, that's going to be an unpredictable measure of oxygenation, which is going to depend more on the fact that this was stagnant sort of blood flow. Interestingly, when I was a fellow at the Hospital for Sick Children in Toronto, they did not do arterial blood gases on patients who came to the pulmonary function lab, but they did arterialized blood gas. And what they did was there was a substance in called infrarub, which was a histamine cream. And you put that on the finger. And I can tell you after 10 minutes, that finger was swollen and throbbing. Histamine is a vasodilator. And so if you just poke that with a little lancet, you get bright red free flowing blood. And it turns out that that arterialized PO2 was essentially equal to arterial PO2. And venous PO2 really reflects tissue metabolism, not oxygenation. Note that saturation on a blood gas is calculated from a measured PO2. It's not directly measured. So if there's a significant difference between a measured saturation from pulse oximetry in a patient and the calculated one, you should believe the measured one. Remember that again, saturation is not linear with respect to PO2. Nobody remembers this graph, but you might want to have some place where you can look at it. So PO2 again measures oxygenation. The textbook causes of hypoxia, remember, are diffusion defect, although there is no diffusion defect in animals or man that causes hypoxic rest, hypoventilation, decreased VQ, and right to left shunts. Pulse oximetry is now most commonly used to measure oxygenation, and this is a clever technique I wish I had invented. So basically, one has a light source, and one shines a light through, for example, the finger, okay, and then picks up the light that is not absorbed, that is, any light that is left over. What happens is that oxygenated blood, all right, has a profile of light absorption over different wavelengths, that is, less absorbed in the low frequency range and more absorbed in the high frequency range. Unoxygenated hemoglobin is the opposite. It's a bit less in the high frequency and more in the low frequency range. What happens is that we have a finger, for example, and there's an artery going through it. So there's arterial blood. Now, basically what happens is the pulse oximeter measures what light is absorbed. Okay. Now, all of the tissues in the finger absorb a certain constant amount of light, but the arterial blood, in fact, this pulses. Okay, so one can subtract the basic type and just get the pulse. And again, the measure of hemoglobin during these pulses is a measure of oxygenation of hemoglobin. Very clever. All right. So remember, this measures saturation, not PO2. Okay, PCO2 measures ventilation. All right, it's inversely proportional to alveolar ventilation and to VQ, and PCO2 can be decreased, it's usually what we want to do, by increasing ventilation, decreasing metabolic rate, or in mechanical ventilation, increasing rate, tidal volume, or pressure. Again, PCO2 inversely proportional to alveolar ventilation. We can decrease PCO2 by decreasing CO2 production or metabolic rate, though we don't usually want to do that, or increasing alveolar ventilation, or increasing VQ. Definition: hypoventilation is by definition decreased alveolar ventilation, and it's accompanied by an increased PCO2. Hyperventilation is increased alveolar ventilation, and therefore a decreased PCO2. And again, increased ventilation without a change in PCO2 is hyperpnea. All right, a change in PCO2 is necessary for there to be hyperventilation or hypoventilation. So PCO2 measures ventilation. Arterial PCO2, again, is the best measure of lung function. Blood comes directly from the lungs. PCO2, again, is unpredictable, depends on perfusion and ease of blood flow. And venous PCO2 is not entirely worthless. It can give you a ballpark measure of ventilation. Now, remember that normally mixed venous PCO2 is 46. But if you want to know is somebody in respiratory failure or not, and let's say you have a central catheter in, if you get a mixed venous or a central venous PCO2 of, let's say, 60, all right, you can believe this kid has problems. A venous PCO2 will not tell you whether PCO2 is 46 or 48, but it will tell you whether it's 40 or 60. So it can be useful in that sort of setting. And sometimes in children with BPD, for example, bronchopulmonary dysplasia, if they cough and have an expiratory sort of cough, a kind of cough, they're not taking in much oxygen or exchanging much CO2. So you can imagine that that PCO2 during that cough is not going to be accurate. In that case, if a patient has an indwelling line, you might get a more accurate assessment of ventilation using a venous PCO2. The textbook causes of hypercapnia are hypoventilation and decreased VQ. And again, blood gases relate to VQ. Increased VQ gives you an increased PO2, decreased CO2, PCO2. Decreased VQ gives you an decreased PO2 and an increased PCO2. Okay, acid-base balance. Now, turns out blood gases are the best measure of acid-base status. Why? Because dissolved CO2 and hydrogen ion are related in blood by this equation. So water plus CO2 forms carbonic acid, which dissociates to hydrogen ion and bicarb, which is usually combined with sodium. there are basically only two types of acid-base abnormalities. They're respiratory acidosis or alkalosis and metabolic. Respiratory, because the respiratory system is the most important. Metabolic is a wastebasket that includes all other causes that are not respiratory. For respiratory acidosis, obviously if it's an acidosis you have decreased pH, you must have an increased PCO2. And likewise for a respiratory alkalosis, you have an increased pH and you must have a decreased PCO2. If it's a metabolic acidosis or alkalosis, there is no change in PCO2. So this is basically the way that you can tell. And then if you add bicarb, for example, or measure bicarb, respiratory acidosis alkalosis will have no change in bicarb. But in a metabolic acidosis or alkalosis, the change in pH is determined entirely by bicarb, not by PCO2. All right. Now, I'm about to reveal to you a secret that should be shared only among pediatric pulmonologists in terms of how to interpret blood gases and acid base. I would like all of you to stand, raise your right hand, and repeat after me. I state your name, do solemnly swear by my majestic and elegant lungs that I will not reveal the sacred mysteries of respiratory physiology which I am about to receive, except to those individuals similarly committed to search for the truth. Okay, so you've now been sworn in. You cannot share these secrets with others except those who are similarly inclined. So here it is. For pure respiratory acidosis, for every increase in PCO2 by 1 torr, pH falls by 0.01 units. Conversely, for pure respiratory alkalosis, for every fall of 1 torr, pH increases by 0.01 units. Now, some of you may have learned a 1 to 0.8. Don't worry about that. The math is a lot easier this way, and it's close enough for government work. So first of all, it's not rocket science. So how do we apply this? So we're going to have a series of questions, at least, for you to try and figure out. The first one, I admit, is easy, but we're going to go through it just to understand the method. So what is the acid-base status? We have a pH of 740, PCO2 of 40, PO2 of 95. Is this metabolic alkalosis, acidosis, respiratory acidosis, alkalosis, or normal? So the first thing we want to do is look at how the pH, PCO2, primarily for acid base, differ from normal. So 7.40 is a normal pH for arterial gases. PCO2 is 40 is a normal PCO2, so there's no difference here. The next question is if or what would be the pH for the PCO2 that we have. So in this case, what would be the pH for PCO2 of 40? And of course, it would be 46. And then to determine the metabolic difference, we want to know the difference between the observed and that which would be predicted by respiratory events alone. So in this case, it's none. And in this case, we have essentially a normal blood gas, normal capnia, no metabolic or respiratory acidosis or alkalosis. So this is normal, right? So that would be the right answer. All right, now let's get a little bit more complicated. pH of 7.2, PCO2 of 60, all right? Is it a metabolic acidosis or alkalosis, respiratory acidosis or alkalosis, or normal? Just take a minute. All right, so in this case, the pH is decreased 20 hundredths of a pH unit. PCO2 is increased 20, okay? So the next question is, what would the pH be that you would expect from PCO2 of 60? Remember, it's 1 up, 1 down. So PCO2 is up 20 torr. So the pH is going to have to be down 20 hundredths of a pH unit, which would be 7.2. All right. Is there a metabolic component? So the observed minus, if there was a respiratory problem alone, in this case is 0. There's no metabolic component. So this is, in fact, a pure respiratory acidosis without any metabolic compensation. There's no metabolic component here. All right? So that's the correct answer. What about this blood gas? So here we have a pH of 7.40 and a PCO2 of 60. So is the respiratory acidosis with metabolic compensation, respiratory acidosis without metabolic compensation, metabolic alkalosis with respiratory compensation, or metabolic alkalosis without respiratory compensation? So let's first look, the pH is normal, all right? PCO2, however, is up 20. So what would be the pH we would expect for a PCO2 of 60? So this is up 20, so the pH would have to be down 20 hundredths of a pH unit, or 7.20. All right. Now, is there a metabolic component? So in this case, 7.4 minus 7.2 does give us a difference. That is, there is a metabolic component, but what is it? How can we calculate it? So here's the second easy rule. Half the difference between the measured pH and the pH if there was only a respiratory process is the base excess. So how does that work? In this case, our measured pH was 7.4. The expected pH for a pure respiratory acidosis was 7.2. 7.4 minus 7.2 is 0.2 or 20 hundredths of a pH unit. So the base excess is half that, 10. And the bicarb would be a normal bicarb, 20 plus 10 or 35. All right? Everyone okay? So here we have a metabolic component of 10. Again, that's 7.4 minus 7.2 is 0.2 or 20 hundredths of a unit. Half of that is 10, and that's your metabolic component. So this is hypercapnia. So there is a respiratory acidosis, even though the pH is normal, but there is a complete metabolic compensation. Why complete? Complete because the pH is normal. Right? So metabolic compensation completely compensated for this respiratory acidosis. So in this case, the answer is a respiratory acidosis with metabolic compensation, in this case, complete. What about this one? So here we have a pH of 7.50, PCO2 of 30. So is it a respiratory alkalosis with metabolic compensation, respiratory alkalosis without metabolic compensation, respiratory alkalosis with respiratory compensation, metabolic alkalosis without respiratory compensation? So there is an alkalosis, obviously. So let's look. So pH is up 10 hundredths of a pH unit. PCO2 is down 10. For PCO2 of, sorry, PCO2 is down 10. PCO2 of 30, right? What pH would you expect? It would be 10 higher than normal, or 7.5. So is there a metabolic component? Observed minus if there's respiratory problem only is 0. So there's no metabolic component. So this is hypocapnia. It's a respiratory alkalosis without any metabolic compensation. Okay, so that's the correct answer. Everyone hopefully getting the idea of how to do this. Okay, we'll get a little bit more complicated. Well, maybe not yet. So here we have a pH of 7.2, PCO2 of 40. So is this a respiratory acidosis with metabolic compensation, respiratory acidosis without metabolic compensation, metabolic acidosis with respiratory compensation, metabolic acidosis without respiratory compensation? So what is it? So here the pH is down 20 hundredths of a unit, PCO2 is 0. So the pH one would expect for a PCO2 of 40 is 7.40. Is there a metabolic component? Yes. It's 7.2 minus 7.4. So in this case, that's minus 0.2 or minus 20 hundredths of a unit. And again, the metabolic component is half that. So it's minus 10. So here we have, sorry, that should be normal capnia. I apologize. So we have metabolic acidosis without respiratory compensation. Okay, there's no change. in respiration here, but there is a metabolic component. So this is a metabolic acidosis without any respiratory compensation. All right, 7.3 pH, PCO2 of 20. So is this respiratory alkalosis with metabolic compensation? Is this respiratory alkalosis without metabolic compensation? Is this metabolic acidosis with respiratory compensation? Or metabolic acidosis without respiratory compensation? So let's look. So the pH is down 10 hundredths of a pH unit. PCO2 is also down 20. All right. So how do we figure out what's going on here? So the pH you would expect for a PCO2 of 20, if this were solely a respiratory problem, would be 20 greater than normal, right? Opposite direction. So it'd be 7.60. The metabolic component is the observed minus for respiratory only, 30 hundredths of a pH unit. Half of that's the metabolic component, which is 15. And again, this is negative, right? So it's minus. So minus 15. All right. So this would be that there is both a respiratory alkalosis, right? Hypocapnia, and a metabolic acidosis. We just saw this metabolic component here. How do you decide which one is primary? So it turns out that a compensatory acidosis or alkalosis will never overcompensate. Since the pH is acidotic, this is a primary metabolic acidosis with a respiratory compensation. A metabolic acidosis would never overcompensate for primary respiratory alkalosis. All right. So in this case, we have a metabolic acidosis with a partial respiratory compensation. Why partial? Because we're still acidotic. If it were complete compensation, then the pH would be normal. Okay? So this is the answer to this one, a metabolic acidosis with respiratory compensation, in this case partial. All right, how about this one? pH 7.5, PCO2 50. So respiratory acidosis with metabolic compensation, respiratory acidosis without metabolic compensation, metabolic alkalosis with respiratory compensation, respiratory alkalosis without respiratory compensation. So the pH is up 10 100ths of a pH unit. PCO2 is up 10. All right. For a PCO2 of 50, we would expect a pH of decreased 10 hundredths of a pH unit, so 7.3. Observed minus for respiratory only is 0.2 positive um, pH units or 20 hundredths of a pH unit. So the metabolic component is half that or plus 10. Okay. So what do we have here? Because the pH is alkalotic, the primary problem is probably the metabolic alkalosis. So we have hypercapnia, so there is some respiratory acidosis, but we have a metabolic alkalosis, which is primary, and a partial respiratory compensation. Again, partial because the pH is not down to normal. Now, strictly speaking, the body doesn't generally do a respiratory compensation to go into respiratory failure, if you will, to compensate. But we do know that alkalosis, and primarily hypochloremic alkalosis, does depress breathing. So in this case, it's probably more correct to say that we have a metabolic alkalosis causing respiratory depression. All right? But metabolic alkalosis with a respiratory compensation. Okay, so pH 7.2, PCO2 20. Is this a respiratory alkalosis with metabolic compensation or without? Metabolic acidosis with respiratory compensation or without? Okay. So we have a pH that's down 20 hundredths of a pH unit. We have PCO2 that's down 20. Now remember, these two should balance. Okay, so the fact that they're both 20 does not indicate that this is purely a respiratory problem. So for a PCO2 of 20, we would expect a pH of 20 hundredths of a pH unit higher than normal, or 7.6. So the metabolic component is 7.2 minus 7.6, or 40 hundredths of a pH unit. Half of that is 20, and this is negative, so the metabolic component is minus 20. All right. So the bicarb here would be a normal bicarb of 25 minus 20 would be 5. Obviously pretty acidotic. There's basically acidosis here, so the metabolic component is primary and the respiratory is compensatory. So you have hypocapnia, you have a metabolic acidosis with partial respiratory compensation. Again, partial because the pH is not returned entirely to normal. This would be classical for severe diabetic acute acidosis, for example. Okay, metabolic acidosis with a respiratory compensation, partial. All right, so using blood gases, acute or chronic CO2 retention. All right, so acute hypercapnia will cause acidosis, as you've seen, but the body does not like a persistent acidosis. I don't know if any of you remember maybe in high school physical education classes where you had to run maybe a 40 or 50-yard dash, fast as you could. Did this in about 10 to 15 seconds. Okay, at the end of that, how'd you feel? You didn't feel particularly good. That's because you were acidotic. Your body did not have time to mount the cardiorespiratory mechanisms required to fuel that energy. So you did it all anaerobically and produced lactic acid. You were acidotic. Okay? So that is not something the body likes. So if PCO2 remains elevated, the kidneys will conserve bicarb to raise the pH to normal, but this takes time. So respiratory acidosis without a metabolic compensation is acute. Respiratory acidosis with a metabolic compensation is chronic. Now, how much time does it take? Um, to be honest with you, I can't really find good answers to this question in the literature, but you can assume that the higher the CO2, the longer it's going to take, at least for a complete compensation to occur. A 16-year-old girl with cystic fibrosis is acutely ill. Her blood gas shows pH 7.30, PCO2 50, PO2 70. Is it acute or chronic? So the answers are acute respiratory acidosis only, chronic respiratory acidosis without an acute exacerbation, chronic respiratory acidosis with an acute exacerbation, chronic respiratory acidosis with acute improvement, metabolic acidosis without respiratory compensation. Okay, so let's look at the blood gas. All right, pH is down 10 hundredths of a unit, PCO2 is up 10 torr. For a PCO2 of 50, we would expect a pH that's down 10 hundredths of a unit, or 7.30. So there's no difference here, no metabolic component. So this is respiratory acidosis without any compensation. So therefore, this is an acute problem. All right, this is an acute change in this individual. And here's the answer: acute acidosis only. So if you saw this kid in the emergency room, you would have to be worried that this is an acute worsening. All right. So another example, same 16 or different 16-year-old girl with CF, acutely ill, blood gas shows 7.40, PCO2 60, PO2 60 is acute or chronic. So again, the answers, choices are acute respiratory acidosis only, chronic respiratory acidosis without acute exacerbation, chronic respiratory acidosis with acute exacerbation, chronic respiratory acidosis with acute improvement, metabolic acidosis without respiratory compensation. So look at those for a second. Okay, so if we look at the pH, it's normal. It's not different from normal. PCO2 is up 20. So for a PCO2 of 60, which is 20 above normal, we'd expect a pH that is 20 hundredths of a pH unit below 7.20. So there is a metabolic component. The difference between observed and respiratory only is 20 hundredths of a pH unit. Half of that is 10 plus 10. So there is a metabolic component of 10. All right. This is chronic respiratory acidosis because there's a metabolic alkalosis which indicates compensation. So it's chronic respiratory acidosis, right? There's an acidosis here. But the pH is normal, so it means that there's been complete compensation and that this is a chronic problem should be, sorry, without acute exacerbation. If you saw this kid in the emergency room, I mean, you might worry about the PCO2 of 60, but at least you know it's not an acute change. This has been something she has been doing chronically. 16-year-old girl with cystic fibrosis is acutely ill. Her blood gas shows 7.3, PCO2 70, PO2 55. Is it acute or chronic? And the same choices: acute respiratory acidosis only, chronic respiratory acidosis without acute exacerbation, chronic respiratory acidosis with acute exacerbation, chronic respiratory acidosis with acute improvement, metabolic acidosis without respiratory compensation. Okay, here the pH is down 10 hundredths of a unit. PCO2, however, is up to 30. All right. For a PCO2 of 70, you would expect, because it's up 30, a pH that's down 30 hundredths of a pH unit, or 7.1. All right. The pH is actually 7.3, so there is a metabolic component. The difference here is 20 hundredths of a pH unit. Half of that is the metabolic component. So that's a positive metabolic component of 10. And so what we have here is a chronic respiratory acidosis, right? Because there is some compensation, but the pH is still low. So this indicates that there's been an acute exacerbation of this person's chronic respiratory acidosis. All right. So it's chronic and acute, or acute on chronic respiratory failure in this case. There's been an acute exacerbation. So one would need to worry that something acute has happened to this child that is different than this child's baseline. What? No blood gas? So this is not an uncommon scenario that we see. We're asked to see a 26-month-old male with chronic lung disease of infancy to clear him for retinopathy of prematurity. Surgery. He's generally been healthy except for 3 admissions for pneumonia since ICU discharge, but that's over 2 years. He's on albuterol and budesonide. Is he stable for surgery and general anesthesia? After yelling at the resident for calling you to consult without a blood gas, not that we would ever yell at a resident, you notice that he, the patient, has the following electrolytes: sodium of 140, K of 4.3, chloride of 94, and bicarb of 30. Is he in respiratory failure, and how can we tell? What is his chronic PCO2? All right, you've got bicarb here of 30, that's the key. So is it 40, 50, 60, 70, or 80? So the key here is the same way we calculated a metabolic component from blood gas, we can go backwards. So our patient's bicarb is 30, which is higher, 5 higher than normal. Now, assuming this is compensation for chronic CO2 retention, and that's important, there can't be another cause of a metabolic alkalosis like diuretics, for example. Okay, assuming this is a metabolic compensation for chronic CO2 retention, the PCO2, the baseline PCO2 difference is twice the bicarb difference. So the PCO2 in this case will be 5, so the bicarb is 5 times higher than normal. 2 times 5, TOR higher than normal, or about 50. The answer here is that the chronic PCO2 is going to be 50, but let me just tell you that bicarb reflects chronic PCO2. Any of these PCO2 values could be associated with a bicarb of 30, all right? So if the patient was unstable and acutely ill, one could have a theoretically PCO2 as high as 70 or perhaps as low as 40, depending on the acuity of the person's situation. But this would be the chronic value. All right. Similar story, asked to see a 26-month-old male with chronic lung disease of infancy to clear him for retinopathy of prematurity surgery. He has generally been healthy except for 3 admissions for pneumonia since NICU discharge. He's on albuterol and budesonide. Is he stable for surgery and general anesthesia? After yelling at the resident for calling you to consult without a blood gas, you notice is the following electrolytes: sodium 140, K 4.3, chloride 94, bicarb 40. Is he in respiratory failure? How can you tell? So what is his chronic PCO2? So think for a moment about what we did last time. Bicarb here is 40. Is his chronic CO2 40, 50, 60, 70, or 80? Give you a minute. Okay. So our patient's bicarb is 40, which is 15 higher than normal. So again, assuming this is metabolic compensation for chronic CO2 retention, the CO2 difference is quite twice the bicarb difference. So it'll be 2 times 15 in this case, or 30 higher than normal, or 70. This child's chronic CO2 is 70. I will tell you, sometimes these kids can have that level of CO2 retention and not look particularly sick, because if it's chronic, they've adapted to it. And they're not particularly tachypnic or showing any distress. Remember again that this reflects chronic PCO2, and any of these PCO2 values could be associated with a bicarb of 40. So it could be as high as 90 if the patient were acutely decompensating here with a pH of 7.2, and perhaps as good as 60. So the point here is that using electrolytes alone, you can get some idea about the adequacy of ventilation. And I love to do this for residents who haven't been exposed to this, because we say you know how to get blood gas because PCO2 is probably going to be near 70, and they get it, and of course it is. All right, so let's summarize. Blood gases, basically, PO2 gives you oxygenation, PCO2 ventilation, and pH acid base. Respiratory acidosis, for every PCO2 increase of 1 torr, pH falls 0.01 units. And base excess is 5 times the pH difference observed minus the expected PCO2. All right? Expected for a respiratory process only. A compensation will never overcorrect. So the primary abnormality is usually indicated by the pH. Acute respiratory acidosis has no metabolic compensation, chronic does, and serum bicarb can give you an idea of chronic PCO2. So next time we will begin to explore pulmonary mechanics, part 1. Thanks again to our director producer, Katie Winter, and thank you for joining me for acid-base balance.